Morning, everybody, and welcome to the National and International Stop Pressure Ulcer Day, which is today across all of the UK and internationally. And welcome to our OSCA small 30-minute webinar giving you a quick background refresh on how to manage pressure ulcers. So my name is Valerie Dowley. I'm an independent tissue viability nurse that works with OSCA.
And I'm Anita Morton. I'm a clinical support nurse for OSCA. So welcome to our session.
We're hoping that this session will be around 30 minutes. We will, if you want to ask any questions, please put the questions in the chat because we've got a lovely Emma who is monitoring the chat and will pop the questions up and we can answer them either as we go or towards the end. And if you have time after the session and you want to stay around and ask any questions for 5 to 10 minutes, then we're happy to do that. So we'll just crack on. And what we'll do is, so we're just going to talk about pressure ulcers and we're going to use the asking model to look at that. So firstly, just a reminder that pressure ulcer is a localized damage to the skin or underlying tissue, usually over a bony prominence, resulting from sustained pressure. So it's when the bone squeezes the tissue, it squeezes between the tissue and the support surface, and it results in a reduced blood supply. And if it's not relieved in time, then the tissues start to die off and you get tissue damage. So the damage can present as intact skin or as a shallow ulcer or as a deep ulcer. And certainly the category 1 and the category 2s, the shallow ulcers, are very, very painful. There are now 7 categories of pressure ulcers. So we all remember the category 1, 2, 3, 4 and unstageable. But in the NHS improvement document, they looked at adding 2 other categories, which are deep tissue injury, which recognises that there's a period of time between when the damage happens in deep tissue and when that tissue completely dies off and becomes necrotic. And that's a period of time when the tissue is looking more bruised and purple rather than dead and necrotic. So that's now called deep tissue injury. And then the 7th category is around pressure damage that's caused by medical devices, and we'll talk about that a little bit more detail. So we're going to just look at this quick refresh through this asking model, and the asking model is a framework where nationally we're trying to get the language of pressure ulcer management and the education of pressure ulcer management to become similar so that everyone is getting the same message. So nationally, they're really pushing this asking model, and asking is assessment of risk, skin inspection, surface, keep moving, looking at incontinence and moisture damage, looking at nutrition and hydration, and giving information. And these are the fundamental principles that we would create and use to care plan for a patient who is at risk or high risk of developing pressure ulcers. So we're going to talk through these one at a time. I'm going to do the first section of it, and then I'll hand over to Anita to do the next bit. So looking at assessment of risk assessment is essential because it allows us to detect individuals who are at risk or high risk of developing pressure ulcers. And that's part of the NICE guidelines from 2014. And even though we use risk assessment tools, we must remember that a risk assessment tool is just that. It's just a tool. It's a bit like a tick box exercise that gives you a platform which you can work with, but it must not be done in isolation. It can't be a solo thing because that won't hold up in a court of law. We need to use the risk assessment tool with our holistic assessment of the patient, looking at the whole umbrella that sits over that patient and what else is maybe influencing their risk. And that then enables us to plan care, to plan it individually for these patients and to provide the resources that they need or the support surfaces they need to manage their ulcers. And then we need to recognise that it's not a one-off process that we need to be looking at reassessing our patients, especially if their condition changes, and even if that's just a temporary change. So you might have a patient who is generally good, has good sort of independent mobility, but then they might get a seasonal flu or a diarrhea and vomiting, and they might take to their beds for 2 to 3 days. And the minute they do that, the minute they come off their feet or their condition changes or deteriorates, we need to be reassessing their risk, because for that period of time, even if it's temporary, they may need additional input like repositioning and surface support. And that also helps us to ensure that the equipment is used right. So it helps to target the right equipment for the right needs and for the right risk, but it also helps in the reverse. So when a patient has had a period where they're unwell, but they improve, if we reassess their risk, we can then free up some high-end equipment by downgrading the patient onto the support surface they might have been on previously. So who is at risk of developing pressure ulcers? Well, everybody is really, from patients, from babies to the very elderly, depending on their risk factors. And really, what starts the risk is when people have not got the ability to be independently mobile, where their mobility gets to a point where they either need to be prompted, they need to be supported, or they need to be encouraged, or it needs to be physically done for them. So patients generally, it's around mobility in the first instance, and then we need to think about things that can add to their risk factor that might affect maybe the quality of their blood supply, or maybe their ability to feel or to understand the sensation. So thinking about people with long-term conditions such as diabetes, critically ill, patients with paralysis, obviously, patients who lack that sensation to be able to understand or feel when something's under pressure, maybe recent surgery, patients with poor nutritional intake, or patients who are seriously dehydrated, because obviously with hydration, it's really important to pump up and keep the veins open and in good condition. There might be psychological or psychosocial factors that we need to think about, moisture-related factors we need to think about. And then we need to really look at the medical devices as well. So this medical device-related pressure damage, which is our 7th category, really is around anything that we use on the patients for treatment or therapeutic purposes. So things like catheters, tubing, oxygen masks, splints, plaster of Paris, even compression stockings, or even TED stockings when they come out of hospital if they've had surgery. We need to be recognizing that anything that we put against the patient's skin that could become compressed has the potential to cause pressure damage. So the next S is around skin inspection and skin care. So we need to be regularly assessing the skin, obviously on admission, and recognizing any areas that we are worried about. And we need to remember some of the fundamental things that are so easy to do. So for example, on white or light toned skin, we need to be using our finger to test for whether the redness on the skin blanches under fingertip pressure. So that is where you put a small amount of pressure on the surface of the skin that's red. If when you take your finger off, it blanches white, that means all the blood vessels are open and moving and in good condition. But if when you take your finger off, it stays red, it means those blood vessels have shut down, and that is category 1 pressure damage. So it's a really good thing to remind yourselves to do, but also to teach your healthcare assistants or anyone who's responsible for moving or toileting the patient, if they see red areas, just to pop their finger on it and just check that it's blanching. This doesn't, fingertip test and blanching doesn't work for darker skin tone, so we need to use our other senses. So we need to think about what we see. Is the area looking different from the surrounding skin? Can we see additional areas of bruising or darkness? Maybe it's maroon or violet color. We need to use our hands and feel and see if there's any temperature changes in the skin. So obviously if skin is inflamed because the tissue is beginning to get damaged, then it'll be hotter than the surrounding tissue. And if it's already died off, it'll be cooler. And we need to use our listening senses, because Category 1 and Category 2 pressure damage are very, very sore. You might not have had pressure sore yourself, but maybe if you've bought a pair of shoes and rubbed the back of your heel down, you'll know how painful that is. And that's very similar to a Category 1 and Category 2. So pain is a big thing that we need to look at. And we need to be asking our patients the right questions. Have they got pain anywhere? Or if they're non-verbal, we need to be looking at whether they're changing the way they're verbalizing things, or whether they're scratching, or whether they're just a little bit out of sorts, and check their skin. We also need to remember that out of sight and out of mind is a big factor here, and we need to be looking at places that we might normally look at. So obviously we need to look at heels, so we need to take socks and shoes off, we need to take stockings off. If they've got bandages on because maybe they've got leg ulcers, we need to make sure we're assessing the heels when they're having their dressing changed. We need to look at other places that might be out of sight, out of mind. So maybe the ears, if they're lying on that side a lot, or if they've got tubing, or even if they've got glasses on and they end up falling asleep in the bed and with their glasses on. We need to be looking at elbows and ankles. We need to be looking at shoulder blades. I've even had somebody with pressure damage on an area of their rib cage because they'd previously broken their rib cage, and that was a bit more prominent. So we need to be looking outside the box, not just at our sacrum and our bottom and our heels as well. So I'm going to hand over to Anita, who's going to talk you around the support surfaces and stuff.
So yes, so thanks, Valerie. So the second S obviously stands for support surfaces, surface selection and their use. So I just thought it's key really just to kind of remind you of the different types of mattresses that there are, and kind of when we might use those mattresses for different patients. So I suppose the first line mattress, and we're probably talking more community-based than anything else with these this sort of starting point of mattresses, because these are the mattresses that we tend to see patients on in their own home, because they're the mattresses they've bought, sort of mattresses that you and I will be using. And these are the standard pocket sprung or even foam, those memory foam type mattresses that we all have at home. And they are suitable for people who are fit and well, able to move. Then they're certainly not suitable for someone who isn't able to move, and certainly for anyone who has any pressure ulcer or even risk of pressure ulcer at that point. So for you community nurses and healthcare professionals out there, you may well be seeing patients on these. I suppose the first line in terms of pressure ulcer prevention is where we then start to see pressure redistribution, high spec foam or viscoelastic style mattresses. So these are high specification products. They are suitable for people who are deemed at risk to high risk in some circumstances. I would just put the caveat in there that you obviously need to check with manufacturer guidance in terms of what risk score or pressure ulcer management and treatment each product would be suitable for. But generally speaking, your pressure redistribution high spec foam would be for people at risk or high risk, certainly from a prevention point of view. But you'd also be looking for those patients who are able to move themselves. So these won't be suitable for any patient that can't reposition themselves or has existing pressure damage, because it is very much reliant on the movement in order to redistribute that pressure. Then I suppose as a next step up, we then have our reactive pressure redistribution mattresses that can either be static foam or static air. In some cases, you also see gel mattresses at this stage as well. And these are suitable for people who are identified kind of medium to high risk, may have some ability to move, but ultimately it could be that they don't tolerate a full dynamic system. So almost the best option in that point would be these reactive pressure redistribution surfaces. So that might be your kind of non-powered hybrid mattresses. So they've got obviously combination of air and foam within them, but it also just could be a very high spec foam, or even the static air mattresses, like I said, whereby as and when your patient moves, the air, foam all kind of mold and redistribute the pressure to the parts of the body that then become more prominent in terms of the bony prominences. And then lastly, we have the dynamic mattresses. You also may know them as active mattresses, airflow mattresses. There's lots of different names for these surfaces, but ultimately they are surfaces that have a pump that will inflate air cells within the mattress, and they inflate and deflate under the patient in a specific cell cycle. So that might be a 1 in 2, 1 in 3, 1 in 4. And these are designed to help with the relieving of pressure, because as and when a cell deflates, it relieves the pressure to that part of the body. However, as and when the cells inflate initially, they will always be at a slightly higher pressure in order to support the body that's then within the surface, on this surface, sorry. So they have other features to them. They may well have a low air loss system to them. They might also help with microcirculation, but they generally are suitable for those patients who are deemed high to very high risk. And certainly those patients that may have a level of pressure damage, and we're talking kind of more the category 3s, 4s, DTIs, unstageable. And these patients are very much dependent on being repositioned. So you would be looking at those patients who are immobile. Often with the air mattresses, what you can sometimes find if patients are mobile, they can almost make patients immobile, because they can be very immersive, which is a good thing, is what we want to see. But for those patients who can move themselves in bed or are able to get in and out of bed, the air mattresses aren't always quite so suitable in that respect, because it almost inhibits the movement. And obviously key as part of pressure ulcer prevention is to keep moving, and we want our patients to keep moving. One thing that is key with all support surfaces to look at how good the levels of immersion and envelopment are. So we want to make sure that our patient sinks into the surface, so that's immersing them into it, and then how it envelops around them. And we want it to envelop around them because we want to increase the surface area. We want to increase their body contact with the support surface. And the reason we want to do that is so that we have a larger surface area for the pressure to be redistributed on. The larger the surface area, the lower we can get the interface pressure, and that interface pressure is the pressure that builds up between the patient and the support surface. So the lower we can get that, the better. And we know that at the bony prominences, that the pressure at the bony prominence can be 3 to 5 times greater of that at the interface. So we need to ensure that's the bit essentially that we can manipulate. That's the bit that we can lower in order to allow our patients to kind of tolerate a lower pressure for a little bit longer. So that moves us into nicely with the K of the Askin bundle, which is keep your patient moving. So obviously I'm sure we all recognise the need to keep our patients moving. If patients are immobile, like Valerie said a moment ago, it just increases their risk of pressure ulceration. So we want to try to keep them moving as much as possible. That said, obviously we don't need them to be moving every sort of few minutes. I mean, ultimately, when you're fit and well, and you're like we're doing right now, all sat in chairs or on settees or whatever we're doing at the moment, we'll be shifting our weight around, probably around about every kind of 10 or 11 minutes. Obviously, our patients can't always do that. So it's up to us, therefore, to help them reposition. So if someone is completely immobile, then we will need to think about how often we reposition somebody. Now, obviously, as the rule, we tend to go with every 2 hours, but we may well change that according to our risk assessment, but also according to our clinical judgment. And that would include looking at patient comfort, patient dignity, in terms of how often we move them. So for instance, we may move them every 2 hours during the day, but we then may want to reposition them every 3 or 4 hours at night so that they can get a decent amount of sleep in between times. And so we're not disturbing them too much. It also may be that we completely leave them at night. If they're on some sort of lateral tilting device, for instance, that might enable us to leave that patient for a little bit longer. In terms of our patients, obviously everyone's anatomy varies, and so the way in which we offload the pressure will be different from one patient to another. So we need to be thinking about whether we can use certain equipment to help our patients reposition. So whether that's using the profiling bed to kind of move them their head up, their knees up, head down, etc., and just shift the weight a little bit. And also if they're kind of have partial mobility, so say they're in a wheelchair, as you can see on the screen there, can we get them to move, and how often are we encouraging them to reposition? So can we get them to shift their weight from one side to another? are they able to stand for a few seconds and then sit down? Anything we can do to try and move to get the blood pumping and to get that tissue reperfused will certainly help. So we want to maybe encourage those patients to be changing their position kind of every 15 to 30 minutes. And actually we can try and give them some visual cues in terms of how often they do that, whether that's as and when the clock gets to a certain time, or whether or not it's every time the ad break comes on, who knows, whatever is best for your patient. And also remember that with clothes comes zips, buttons, seams, there might be wrinkles in bed sheets, tight clothes, etc., which can all potentially cause pressure damage. So we need to be thinking of, are we checking those areas? Are we checking under kind of buttons and zips and things? And are we ensuring that that's negated in some way? And can we put anything underneath those areas to help to redistribute the pressure, reduce that peak pressure that's occurring? Excuse me. And also, if someone's got a sling in place, can we remove that sling? Ultimately, that is better. Obviously, there are some instances where maybe those moving and handling slings cannot be moved. And then in which case, how are we ensuring that there is no pressure damage occurring? Are we checking the skin more regularly? Are we ensuring that the seams aren't touching certain parts of the body? So it's about how physically we keep our patients moving, but it's also about the other things that are in place that are in contact with our patient's skin. So then the I stands for incontinence. I would probably say that we would be looking more at moisture-associated skin damage as well. So we tend to look more at incontinence associated dermatitis when we're looking at the skincare bundle, but ultimately this would include all levels of moisture associated skin damage, so moisture that comes from between skin folds, etc. But in terms of incontinence, ultimately, as and when a patient has an incontinence episode, the urine sits against the skin, and the urine unfortunately is alkaline, and our skin is naturally acidic. And so as and when the urine sits against the skin for too long, it starts to break down that natural protection of the skin. So the acid mantle of the skin, it starts to break that down. And what it does do then is it exposes the stratum corneum, so the top layer of the epidermis, sorry. And it exposes it to bacteria, to toxins, and that ultimately irritates the skin. And then we end up with this red, excoriated, really painful, almost like a burn-like looking skin. And that's so uncomfortable for our patients in residence. So we need to be thinking, how can we protect the skin from this? Because ultimately this could increase the risk of pressure damage, because the skin at that point is very vulnerable. And also what we find is that we find all of this moisture damage from incontinence-associated dermatitis all around the bottom, the sacral area, and that obviously is one area that can be at risk of real severe damage. So we need to be protecting that area of skin. So how can we do that? Well, we can use barrier creams to protect the skin. So that kind of adds another protective layer so that the urine, the feces cannot penetrate through. And ultimately it then protects the skin and will help heal that sort of redness on the skin and allow that to go down. But the other thing we can also do is a good continence assessment. Now, I could talk for England on a good continence assessment, but we are limited on time, so I will be brief in my explanation. But ultimately, if we do a good continence assessment, we can check to see what type of incontinence somebody has, and how we can then support that level of incontinence and try to reduce the incontinence episodes. The main thing we can do, the most important thing we can do, is toilet somebody. So the more often we can toilet somebody, the less likely they are to have incontinent episodes. However, I realise that's not the case for every single patient out there. So if they are then looking to be wearing continence products, you need to be thinking of fitting them correctly. So cup and fold them and ensure that they are in the right size net pants, so that that pad is held firmly so that nothing can leak out. We also want to ensure that your patients are in the right have the right level of absorbency for the product as well. Because if the continence product is too absorbent and it's not absorbing urine, it's going to try and absorb moisture from somewhere, and ultimately it takes it from the skin. So we need to try to obviously prevent that from happening by having the right level of absorbency. Likewise, if the product isn't absorbent enough, then obviously you're going to get a logged product whereby the urine then can't get in, and then it sits against the skin again. And just one other aspect of this, if you're using barrier creams, never wipe the excess barrier cream into the pad, because ultimately that will block the pad from working and render it useless. So then moving on to nutrition and hydration. So obviously the aim for all of our patients is to ensure they get enough calories and protein to maintain a healthy weight. So we're looking at having regular balanced meals, so using all of the food groups according to the nutritional plate you can see on the screen there. And also if required, to have additional snacks as well. We would always do our must screening so that we can ensure that if our patient needs referral to dietitian, that occurs. If they need referral to OTs because they need special cutlery to eat, etc., that is also done as well. But it also enables us to ensure that we are kind of monitoring the nutritional intake of our patients. In terms of hydration, they do say 8 drinks per day. I would say 8 drinks is a little bit subjective, because what cup size one person has, another person will have something either smaller or bigger.
So apologies for that. I think our Wi-Fi just dropped us out very, very briefly. So hopefully we haven't lost too many of you. And I'm going to hand you back over to Anita just to go through that last slide about giving information. Anita,
thank you. Yeah, apologies for that, everybody, but we're back. So in terms of giving information then, so giving information was the G part, I suppose, of the asking bundle was added in 2018, and it really was to highlight and underpin the importance of ensuring that we give information to not only each other but our patients and their families as well. And it's really essential that we share that information so that patients understand why we're doing what we're doing, so we can ensure why patients understand why we maybe have implemented a certain support surface, or why, we're encouraging to eat and drink, or we've, looked at how often they're being repositioned and why they're being repositioned every 2 hours, every 3 hours, etc. So it's really important to sit down with your patient and explain that to them, and also with their families as well, so that they understand. And if these are patients in their own home, or even if they're patients that are being discharged back home, the importance of sharing that education, so that they are able then to understand when they go home what they're looking for in terms of maybe looking at the skin, how often they need to keep moving, keep repositioning themselves, is really key to the continuity of their care.
Yeah, and I think, and then add to, because I think the other side of that is around remembering that we need to give that information to their carers and family, because, we're in healthcare, so we understand kind of some of the language around pressure ulcer prevention. We, even having a 30-minute session like this today gives you that extra knowledge, but people in the normal everyday life don't understand that. And so when you're talking about high-end equipment and you're asking people to move and you're putting them on these funny support surfaces, it can create a resistance because of that lack of information. So I'm a firm believer in that lovely partnership of care where, if it was you and I 30 years time, I'd want to know what you're doing to me, and I'd want to know why you're doing it. And then I would be able to work with you so that we're both on the same journey. So it's about giving that information much, much wider than just to our patient, isn't it?
Absolutely. Yeah, I couldn't agree more.
Yeah. So if you've got any questions for us, please do pop them into the chat. And so that's us done for this session. Sorry about the little dropout. It was just kind of beyond our thing. Anita just wants to show you one other thing.
So obviously this is just a snippet, a taster of what we do here at Oscar. And we have our training academy, which obviously provides different modules of training and education, anything from kind of 1.5 hours through to a 4-hour session on pressure ulcer prevention and wound care, skin inspection, root cause analysis, and also a much lengthier version of the Asking Care bundle. So we do have our brochure here, our new brochure, in terms of what we can provide you here at the Oscar Training Academy. So if you are interested in any of the courses that we may be able to provide you, or any further information, there is a poll on your screen there. If you could just click whether you would be interested or not, that would be fantastic.
Otherwise, have a good Stop Pressure Ulcer National and International Day. remember to have that conversation with your colleagues, your patients, and even your friends if they're in that sort of, if they want that information, because pressure ulcer prevention is everybody's business. It's not just the nurses and the patients and the carers.
And just to add in, we will be doing our usual webinars, the next one on the 7th of December, and this one is around keeping moving. So obviously, if you are interested in that, the registration details will be coming out shortly. So thanks, everybody, and we will say goodbye.
And have a good day.